Guys, I'm Michelle. I'm the VAQI chief, and I'm recording a lecture on fever, which is part of our intern Basecamp series. And I'm going to record this differently than I would for the noon report, just because it's meant to be an interactive lecture. And obviously, if you're watching this right now, you can't interact. And so this is going to be a little bit quicker and more concise, and obviously not interactive. So again, we're going to be talking about fever today. And then I am Michelle, and just as an FYI, the polling doesn't work, so we won't even try to incorporate prior polling results. The objectives for today's lecture are, by the end, I'd like you guys to be able to define fever and generate a general framework for how to approach a new fever, especially when you're on nights or cross cover. Understand the basics of sepsis identification and treatment, feel comfortable with antibiotic resources, and be able to create a differential for non-infectious sources of fever. One of the first questions that I asked all of the interns was, what is a fever? And this is actually a fairly controversial definition. So typically you'll be told that a fever is a single temperature of greater than 38.3 or 101 degrees Fahrenheit, or a temp that's sustained for more than an hour of 38, which is 100.4. This is the answer that you should say on wards. It's what you might be asked by your attendings. However, with that being said, again, this is a little bit controversial. This definition is based on work done in 1868. And since then, some studies have been arguing that we should lower our temperature cutoff for a fever to 99.5 or 99.9. Harrison's, which is one of the gold standards for internal medicine textbooks, actually writes that the normal temperature at 6 a.m. is 98.9 at max, and then the maximum temperature at 4 p.m. is 99.9. And these values are the 99th percentile for healthy individuals. So depending on what time of day it is, you can argue that these should actually be the cutoffs for fever. The next question that I asked people to discuss was a diagnostic workup for fever. And the point of this question was to show how broad of a workup you would have to do if you wanted to order everything under the sun to try to work up a fever. So when I was doing this myself, I came up with a CBC with differential, a BMP, LFTs, blood cultures, a GI PCR, a lumbar puncture, urinalysis with culture, a chest X-ray, a CT, chest, abdomen, pelvis if you're looking for occult abscesses, CT or ultrasounds of the extremities if you're looking for neck fascia or abscesses, a CT or MRI of the brain, a CT or MRI of the spine, a TTE, or if that's negative, a TEE, looking for infective endocarditis, a tagged white blood cell if you're getting really crazy, inflammatory markers, a TSH for thyrotoxicosis, ANA for some of the room stuff, a quant gold, HIV, viral PCRs, and maybe even a procalcitonin, depending on how crazy you want to get. And so the purpose of the slide was to show it would be absolutely ridiculous to try to empirically treat every single fever with only labs. With that being said, we are going to walk through two cases, and the first case is cross cover fever. And so it's July 24th, it's 3 o'clock in the morning, and you're at the university, and you get a secure chat. And John, the nurse, wants to let you know that Mr. Jones in room 832 just spiked a temperature to 38.5. He's just giving you an FYI. And the question is, what do you do first? So go ahead and take a second. You can read through these choices. Number one, would you order broad spectrum antibiotics? Number two, would you say, I have no idea if this is a fever, I'm new, I'm just going to call the ICU to come take a look at him? Number three, would you ask to see the patient's vitals and then go actually see the patient? Number four, would you order blood cultures, chest X-ray, and urinalysis? You're a new intern, you've been told you should do this on every new fever and then go see the patient. Or number five, would you just panic and quit? And so the correct answer here is going to be go see the patient's vitals and actually do an exam. So you ask John and he's able to tell you the rest of the vital signs. It's a temperature of 38.5, a heart rate of 90, a respiratory rate of 18, a blood pressure of 110/70, and then your patient is saturating 91% on room air. As you're walking over to see Mr. Jones, you're reading the summary statement that the day team gave you, and they want you to know that Mr. Jones is an 89-year-old guy. He has a history of COPD, CAD, and dementia. And he is here just pending placement for failure to thrive. He's currently in hospital day 7. They're not too concerned about him. They're really hoping a sniff accepts him soon. So when you go examine Mr. Jones, I want you guys to be really focused in your exam. This is not the time that you are rewriting the book. You're not doing a 20-minute history and physical. It should be focused. The first thing to always check is this patient sick or not sick? And so you are able to find that Mr. Jones does not look like he's in any kind of distress. Importantly, he's mentating at his baseline, so he's still ANO times 2. You're not concerned that his brain isn't getting perfusion. You do a good lung exam and you hear new wheezes and maybe some rhonchi, and this has not been noted on prior exams in the notes. You press on his bladder and belly, there's no tenderness, there's no CVA tenderness. And then his skin also looks good. So here, within about 5 minutes, you've able to achieve a good exam, and hopefully you're narrowing in on the fact that there's something going on probably with his lungs. The next question that I asked the interns to discuss was labs and imaging. So what do you want to order and in what priority? The purpose of this exercise was to show that the labs you order, just like your physical exam, should be fairly tailored. So if Mr. Jones has been here for 7 days, they're not getting routine labs on him. It's certainly reasonable to consider getting a CBC, making sure that there's no new leukocytosis. You can consider a BMP, make sure that there's not a new AKI that again would make you concerned that for some reason he's not perfusing, although with his vital signs, that's a lower concern right now. Anytime you're concerned about a hospital-acquired infection, you should be getting blood cultures. And so in this patient, we're concerned that there's something going on with his lungs, which the giveaway will be that this is probably going to be a hospital-acquired pneumonia. So we should be getting blood cultures in him. If this was a patient that had come in with a similar picture, but to the ER and had been in the community, we would not necessarily need blood cultures for something like a community-acquired pneumonia. One of the other things that I liked to point out for our interns is that blood cultures, it's always okay to err on the side of getting them, especially as a new intern, but be aware that they're not entirely risk-free. And so if one of those blood culture sets come back with blood gram-positive cocci and clusters, you are sort of forced into treating the patient with vancomycin until they result. And then when it results as like a coag-negative staph, you realize that you've been treating a contaminant, not a true bacteremia. And we see that a lot. And so just be aware that anytime you do get blood cultures, you run the risk of seeing a false positive. And then the last thing that you can consider is a lactate. Again, this patient's vital signs and exam are fairly reassuring, so it's not needed now, but it's something to always be thinking, am I concerned about end organ perfusion? And then deciding if you are to get a lactate. I'd like you guys to notice that there's not a urinalysis listed here, and that's actually intentional. So in a patient where you have another source of infection, they're able to speak to you, they seem more or less oriented, you're able to do an exam and you've got a clear source and they're not giving you any kind of urinary symptoms. There's actually no need to do a urinalysis. It would be very unlikely that he's got an asymptomatic UTI and a pneumonia as the cause of his symptoms, and doing a urinalysis gives you a much higher likelihood of finding bacteriuria that you are then forced to think about treating. So you do not need to do a UA in this patient. Then for imaging, chest x-ray is a pretty clear call here. So you get the chest x-ray, it comes back and you see this beautiful pneumonia right here. The takeaway from this slide, and this is not a chest x-ray lecture, but this is a right upper lobe pneumonia. So a right middle lobe pneumonia, which a lot of people would call this a middle lobe pneumonia when they're early on in their training, tends to be close to the heart border. Whereas here you can very clearly see the fissure and then the pneumonia superior to the fissure, which tells you this is a right upper lobe pneumonia. A right middle lobe pneumonia would be where my cursor is, and then a right lower lobe pneumonia would typically be down here. This patient also maybe has a little bit of effusion, you can see right there. It's not terribly important as to where the pneumonia is, other than the fact that a nice like socked in lobar pneumonia can make you more concerned about something like strep pneumonia, whereas like a right lower lobe pneumonia can make you more concerned about aspiration. But in the end, we're going to be treating this gentleman the same no matter what lobe his pneumonia is in. So the first step in treating a patient with an infection and a fever is figuring out, does your patient have sepsis? And so I want you to take 2 seconds to yourself and think, yes, I do believe he has sepsis, no, or you just have no clue. And the answer here is going to be that he does not currently have sepsis. And so there's 2 different ways that we look at sepsis. A couple of years ago, people mostly used SIRS, or systemic inflammatory response syndrome. And if a patient had 2 or more of these plus a source, they were considered to have sepsis. So basically, if they were febrile or had a low temperature, if they were tachycardic to greater than 90, tachypnic to greater than 20, or had a leukocytosis or leukopenia, and then a source, they had sepsis. Since then, we've moved more towards a Q-SOFA, which is a sequential organ failure assessment questionnaire, and the Q stands for quick. And so this can be the quick screening tool that you use. And if your patient is altered, hypotensive with a systolic of less than 100, or had tachypnic with a respiratory rate of greater than 22, if they have 2 of these 3, they are considered as being positive on the Q-SOFA, and this should trigger a more robust look for why they are septic, and then potentially consider filling out the full SOFA questionnaire. And again, as a reminder, these were his initial vital signs. And so I'll just tell you guys, we'll say he does not have a leukocytosis. And so this patient does not have sepsis by either definition. The reason that we look at both SIRS and QSOFA is they have very different specificities and sensitivities. And so in-hospital mortality specificity for QSOFA is reasonably good. It's actually in the high 70s, where it's obviously terrible for SIRS. However, the sensitivity for SIRS is much better. It's in the low 80s as compared to QSOFA, which depending on the study is anywhere between 37 and 56%. And so basically, what this means is that QSOFA, if the score is greater than 2, is pretty reliable in terms of telling you that this patient has a higher probability of mortality in the hospital from their sepsis. And so this is a patient who, if they're flagging QSOFA, you really want to watch and consider a higher level of care. However, with the sensitivity, a low QSOFA does not mean that they have a decreased mortality risk. And so it's good at telling you if somebody's sick. It's not really good at telling you if somebody's not sick. SIRS, however, has lower specificities, but higher sensitivities. And so SIRS is going to be better at telling you which patients are at low risk for having a high in-hospital mortality. Your attendings may variably use either one of these. I think that I still use SIRS in my notes, but I try to document both, and this is the reason why. So you have done a really good job of examining your patient. Now it's time to come up with a diagnosis. And in Mr. Jones, he likely has a pneumonia, and we should call this a hospital-acquired pneumonia. So by definition, a hospital-acquired pneumonia is a pneumonia that develops after 48 hours in the hospital. And in this patient, he has probably risk factors for aspiration. And so I had some interns ask, could this be an aspiration pneumonia? And the answer is obviously, of course, it definitely could be. But overnight, when you're getting this call, it's always good to go broad. The last thing you want to do is undertreat somebody, especially if they've got this bad pseudomonal pneumonia, hospital-acquired pneumonia. And so that's why we should say that at least overnight, this patient could be considered to have a hospital-acquired pneumonia. And in terms of antibiotics, you want to go broad. And so this is a patient who, per most of the hospital antibiograms, should definitely be getting cefepime. And then depending on their risk factors for MRSA, which is going to be a history of IV antibiotics within the last 90 days, a personal history of MRSA in the past, or hypotension, you would add vancomycin depending on those factors. And so for our patient, we're going to go ahead and start cefepime. He has been in the hospital long enough, but doesn't have a personal history of MRSA. He doesn't have any recent IV antibiotics, and he's not in septic shock or hypotensive. And so we're going to do monotherapy with cefepime. Antibiotics, I think it can be really hard to memorize all of the different antibiotics that you can give for every different fever. And so I would encourage you guys to focus more right now on learning the resources as opposed to empiric treatment. And so these are some resources. The first one is the antibiotic resource for Denver Health. If you don't have this downloaded, I definitely recommend downloading it. You can go to this website and then it will auto download an app onto your phone. And it has all of the most common infections, including what Denver Health recommends as first-line treatments for those infections, depending on their personalized antibiogram. We have something similar for the university. Some people have been able to download Dorsata and get it to work. And then there's also an antibiotic handbook that you can find floating around at a lot of the workstations at the university that has some incredible algorithms and then all of the recommended empiric antibiotics. The VA also has something similar. It's printed out in all of the resident workrooms. You can always call a pharmacist. They're amazing. Their wealth of knowledge is truly remarkable. And so if you're ever concerned, call a pharmacist, run the clinical scenario by them, and they can usually give you recommendations. You can always talk with your senior, and then UpToDate can also be a good resource. So you feel great. You've started cefepime. Mr. Jones is thriving, but then 4 hours later, you get another secure chat, and it's John again. And he wants you to know that Mr. Jones is now fevering to 39. His pressure is also getting softer. He's 87/56. He's tachycardic to 110. He's tachypnic to 23. And he also has a new O2 requirement. He's now needing 2 liters to keep his oxygen at 92%. And so all of this is bad. If you should be looking at these vital signs and thinking, this guy is sick. So he absolutely has sepsis now, which needs to prompt us to treat him for sepsis. And so this is the Surviving Sepsis campaign. They recommend a 1-hour bundle, which we'll talk about in just a second. But essentially, once you recognize sepsis or septic shock, it should trigger you to get a lactate and then trend the lactate if it's greater than 2, which would be elevated. Getting blood cultures before giving antibiotics, although you should never delay antibiotic administration if for some reason you can't get blood cultures. Then start broad spectrum antibiotics tailored towards what you think is causing the infection. Although if you're unsure, you should go broad with something like Basecamp. Starting 30 cc per kilogram fluid bolus, especially if somebody is hypotensive or has a lactate of greater than 4. And then having a low threshold to start vasopressors if people are remaining hypotensive during or after fluid resuscitation, trying to get that MAP greater than or equal to 65. This is something that CMS actually grades us on. So the Center for Medicaid and Medicare, all hospitals will have their metrics published, and it helps guide our reimbursement as well as our patient safety scores. And so not only is this the right thing to do for patients, but it also directly impacts how our hospitals are graded. And then the sepsis bundle, which is sort of these steps 1 through 5, all of the sepsis bundle criteria have to be met for us to get a check mark in terms of treating sepsis correctly. So this is what you guys should remember. With that being said, there's been a lot of studies since these guidelines were published that have looked at outcomes. And the most recent surviving sepsis guidelines recommended a 1-hour bundle as opposed to a 3-hour bundle, which means that all of these steps are at least started within 1 hour. And there's been several studies that have shown that 1 hour is not necessarily better than 3 hours when it comes to lowering mortality or reversing shock. And so for you guys, I think as long as you're doing all of this bundle within 3 hours, you're doing a great job. The other part that can be a little bit controversial is this 30 cc's per kilogram fluid resuscitation. And so right now it is something that we recommend doing. And with that being said, there is active research being done about whether or not this is the gold standard, if we should be doing less fluid, if we should be reaching for pressors a little bit sooner if people are hypotensive. And so there's actually a study going on at the university looking at earlier pressors. So for now, the thing to know is fluids if somebody is hypotensive, but don't be surprised if these guidelines change in the next 5 to 10 years. The Joint Commission also feels very strongly about sepsis, appropriately so. So sepsis is the leading cause of death in hospitalized patients. Around 220,000 Americans die each year from sepsis, and it has an in-hospital mortality rate of between 25 and 50%. So it can be really dangerous if somebody has sepsis. It's also the most expensive disease that we treat. It costs us approximately $17 billion each year. So you will not escape residency without treating somebody with sepsis or septic shock. It's an extremely common diagnosis, and it's really important to know that it is life-threatening and we should be doing fluids and antibiotics. So you very astutely pick up that Mr. Jones does in fact now have sepsis, and you give him a fluid bolus, you start some pressors if he's not responding to the fluids. And then because he now is hypotensive, you additionally start vancomycin. And congrats, he lives. You did a great job. You treated him. He is thriving. The next case is September 24th. It's 3 a.m. and you're at the VA and you get a secure chat, and it's John again. And he wants you to know that Mr. Jones is back. If you remember him from a couple months ago, and he just spiked a temperature to 38.4. And John wants to know if you want to do anything. You remember this lecture, so you decide that you are going to look at his vitals, chart review, and exam. And so looking at the vitals, you find that he is febrile. He's also tachycardic, tachypnic, hypotensive, all of which is incredibly concerning, but is doing great on room air. The summary statement that the day team has left you is that this time he is here transferred from his SNF with a pan-sensitive E. coli catheter-associated UTI. For some reason, somebody stuck a catheter in this guy, and by golly, now he's got a UTI. They very helpfully share with you on the cross-cover handout that they switched him from ceftriaxone to oral Ceftonir today. And when you go to see him, it's a little bit concerning. He's not in any apparent distress, but he is only ANO times 1, which is less than his baseline, so he's more confused. His lungs are clear. He has suprapubic tenderness. His urinary catheter, for some reason, is still in place. We really need to get that out, but it's draining pretty gross urine. He's got right CVA tenderness. His skin looks fine. So you are thriving, you're well into your intern year at this point, and you pick up that he is septic, and it's probably from a pyelonephritis. Because he is septic and because he's hypotensive, decide to get a CBC looking for a leukocytosis. You get a BMP to see if his kidneys are doing fine. You absolutely get that lactate, you get the blood cultures. And then since this is a little bit weird and he's getting worse, not better, you go ahead and decide to get a repeat urinalysis with culture just to see if there's something new that's happening. And then you also decide that, again, this is kind of a weird story. For some reason, he's getting worse, not better, despite having been on the appropriate antibiotic for E. coli. And so you go ahead and do an ultrasound, looking for, does he also have potentially a renal abscess and there's a problem with source control, or does he have a stone actually and there's a nidus for infection and that stone needs to come out. You also, while you're waiting for everything to come back, start fluids at 30 cc's per kilogram. Again, you're starting pressors if he's not fluid responsive. And then you are transitioning back to IV antibiotics. And since he's getting worse, not better, and is profoundly hypotensive, you decide to go ahead to broaden to cefepime. You do want that pseudomonal coverage. And then I think it's important to point out that if somebody's doing something that's unexpected, so they were doing better, you have a bug, you have them on a drug that the bug is sensitive to, it should make you stop and think, do I have the wrong bug or do I have the wrong drug? What else is going on? And so in this patient, maybe the E. coli was not actually the etiology. Maybe for some reason he's got an ESBL and the microculture data is going to be updated and tell you that it's actually resistant to ceftriaxone and ceftonir. Maybe he has an abscess, and again, it's a source control issue, or maybe he does have that infected stone. But anytime somebody's not behaving the way you would expect, it should prompt you to take a step back and say, what am I missing? It's also important to always review culture data. And so you'd be surprised how many times you'll go back and find that this patient was actually here 3 months ago and they had VRE at that time, or they were here 3 months ago and they did have an ESBL. So making sure that you're aware if a patient has a history of multi-drug resistant organisms, which would prompt you to reach for a different antibiotic than you otherwise might. And then have a really low threshold to review with pharmacy if you do find that a patient has a bunch of different MDROs or allergies that make it hard to choose an antibiotic. The pharmacists are brilliant and they're always happy to go over this with you at all of our hospitals. So you broaden him back, you fix those abscess, and congrats, he lives. Again, you guys are doing great. This next slide is supposed to be busy on purpose, and it's not meant to be something that you memorize. So these are the most common infectious sources of fever. And the goal of this slide is to show you how much overlap there is empirically. So we've got our pneumonias, our UTIs, our skin infections, our abdominal infections, CNS infections, and then sepsis of unknown etiology. And you'll see across this top line, in patients that are at a low risk of a multi-drug resistant organism, ceftriaxone makes an appearance a lot of the time. And then if you go down to this next column, when people have a high risk of a multi-drug resistant organism or severe sepsis, you'll see that cefepime and vanc make an appearance a lot of the time. And so this slide is really just to show you that you don't need to be familiar with 100 different antibiotics to be able to quickly empirically treat somebody. There's really a handful that we typically reach for, assuming a normal infection with one of our more typical bacteria. The next thing that I want to talk about is something called neutropenic fever. And this is because it's an incredibly important diagnosis and is a cannot miss diagnosis. And so as a reminder, neutropenia, it depends on the institution, but it's typically defined as an absolute neutrophil count of either less than 1,000 or 1,500, with severe neutropenia being an ANC of less than 500 or an ANC of less than 1,000, but with an anticipated decline to less than 500 in the next 48 hours. So this is a patient with an ANC of 900, but they just got chemotherapy and you're expecting their ANC to plummet. The definition of fever in these patients is the same as the traditional definition. And so it's going to be a single temp of greater than 38.3 or a sustained temp of greater than 38. But this is an emergency. This is absolutely an emergency and it cannot be missed. So antibiotics in this case need to be given within 30 to 60 minutes, not that 3-hour sepsis bundle that we talked about before. And the reason for this is that each 1-hour increase in time to antibiotics increases mortality fairly significantly. So 28-day mortality goes up by 18% for every hour increase. In one study, they actually looked at giving antibiotics within 30 minutes and found a 3% 28-day mortality as compared to giving antibiotics within 60 minutes, which was associated with an 18.1% mortality. So early antibiotics is an absolute must in these patients. The workup is going to be fairly similar otherwise. So you should still be doing a targeted history and physical exam with the caveat that you should be paying more attention to the skin and oral cavity, looking for things like mucositis. And then if you, we aren't really doing DREs that often in our febrile patients, but say you were concerned about a prostatitis, this is not the patient to do a DRE and you increase the risk of bacteremia. So no DREs. And then the workup is just slightly more broad. And so getting a CBC with differential, a CMP, so you're getting those LFTs, a blood culture, a urinalysis, and then any imaging that you think is indicated. In terms of antibiotics, we want to cover gram-positive pathogens, but we want to be broad in our coverage. And so the recommendations for an undifferentiated infectious source, but without hypotension, it's going to be Zosyn or cefepime or meropenem imipenem, so getting that pseudomonal coverage. And then if there is septic shock or hypotension, adding vancomycin. If there's a skin or soft tissue source, mucositis, concern for a pneumonia or concern for a catheter-associated infection, you want to get vancomycin on board. VRE, you want linezolid or dapto. And then if there's concern for C. diff, you obviously want to give PO vancomycin. So again, neutropenic fever, can't miss diagnosis. This is something to always be aware of in your cancer patients. The last couple slides are going to be talking about non-infectious sources of fever. And so I think this is a nice flow chart showing you when maybe you should be a little bit more aware that there might be something more than an infection going on. And so typically if your patient is fevering from an infection, they might have chills or rigors. This is more often absent in non-infectious sources of fever. A leukocytosis can be present in both, but is going to be more commonly seen in infectious fever. Pulse temperature dissociation is going to be more common in non-infectious sources of fever. And so this is defined as an absence of a 10-point increase in heart rate for every 1 degree increase in temperature. So for example, if you have a patient that has a temperature of 103 and their pulse is hanging rock steady at 70, that's a little bit unusual and maybe can point you more towards a non-infectious source of fever. Similarly, a continuous fever, so one without a waxing and waning course, is going to be more indicative of a non-infectious source. And then hemodynamic instability or lactic acidosis really should point you towards infection. You always definitely want to cover for infection if this is happening. Non-infectious sources can cause this, so something like malignant hyperthermia, but more typically it's going to be infection. So when we talk about non-infectious causes of fever, I would have our interns shout out a bunch of answers to show how many things can cause this. But when I came up with my list, there's going to be medications. It should be always something that you're looking at. So it can be a direct drug effect. It could be a delayed DRESS. You can have serotonin syndrome, an anticholinergic toxidrome, NMS, or malignant hyperthermia. Gout and pseudogout we commonly see in the hospital, and that can cause a low-grade fever. DVT and PE can be incredibly inflammatory and cause a fever. Pancreatitis, even in the absence of a superimposed infection. Aspiration pneumonitis can cause fever before it turns into a pneumonia. Any kind of our systemic autoimmune diseases, so like lupus or RA, can cause fever. Any of the vasculitises can cause fevers. Malignancy, most specifically lymphoma and leukemia, although any malignancy can do it. Transfusion reactions, it's actually quite common to get a fever when you're getting blood, in part because blood can come with cytokines in it, and that's normal. Although anytime you have a fever with transfusion, you should still be sending off the transfusion workup, which the nurses are really good at triggering. Post-procedure, so for example, post-bronchoscopy, it can be common to get a fever. Withdrawal from things like alcohol, so delirium tremens definitely can give you fevers. Hyperthermia or exposure, severe brain damage, if you knock out the hypothalamus, people can get quite febrile. Same with spinal cord injury and autonomic dysfunction. Hyperthyroidism with thyrotoxicosis, adrenal insufficiency, and then fever of unknown origin. I wanted to include one slide on fever of unknown origin because I think it's a really fun diagnosis. So FUOs were derived back in the 1960s, and the definition was created on an analysis of only 100 cases, although the definition is now considered standard. And so a fever of unknown origin is defined as a fever of higher than 38.3 on several occasions, and it has to last for at least 3 weeks. And then the diagnosis has to remain uncertain after 1 week of intensive study in the hospital. Somewhat interestingly, in the 1930s, 75% of FUOs were undiagnosed, and they decreased this to less than 10% in the 1950s. We're actually back up to around 50% in terms of not getting a diagnosis now. This is maybe due in some part to the easy diagnoses being removed from this pool, and so we've gotten a lot better at diagnosing things like tuberculosis and malignancy, thereby removing them from our pool of FUOs, but it's not entirely clear why it's increasing so much. When they look at a breakdown of what causes these, 22% of the time we'll find a rheumatologic disease, 16% of the time we'll find an infectious disease, 7% will find malignancy, 4% is miscellaneous, and then we never find a diagnosis again in about 50%. This last slide is just some practical fever points to end with. So hopefully by now you realize that not all that fevers is infection, but more importantly, not all infection will fever. So specifically your cirrhotic patients, your elderly patients, your immunocompromised patients. If somebody's showing you that they have a pneumonia based on symptoms, it's not appropriate to wait for them to hit that 100.4 before treating. And then the other thing to keep in mind again is that the definition that we use as fever is maybe not low enough. And so if you have a patient who hangs out at 97 all the time and suddenly they're 99.9 and coughing and have a consolidation, again, this patient probably has a fever and you should be treating them. Last point is that not all fevers need Tylenol, especially on the wards. There's actually no morbidity or mortality benefit to treating fevers on the wards. It's obviously a different story if you're in the ICU and the patient is getting febrile to the point that pressors don't work or you're concerned about their proteins. But in general, we should be treating patients symptomatically, not based on a number. And then final point is please don't schedule Tylenol in your heme malignancy patients. So again, if you are scheduling Tylenol, you can actually miss an early fever, which would trigger you to send the workup and start antibiotics for neutropenic fever. So you should never schedule Tylenol in heme malignancy. And with that, we are done with our fever lecture. If you guys have any questions about any of this, please feel free to text or email. Everybody has my contact info at this point, and I hope that you had a great Basecamp week. Thanks.